SIU School of Medicine. She is the associate professor of pediatrics at SIU Medicine, and she is a neonatologist. Thank you. And somebody that I absolutely adore. She's instrumental in creating this program, and so huge shout out to everything she's doing down there, but also to the things she's doing statewide and on a bigger level. So, welcome, Dr. Leadbetter. We're so excited to have you.
Thank you. I appreciate that kind introduction. Hi, everybody. I do want to thank my fellow members of the Planning Committee for allowing me to have this platform for the next 90 minutes. This is a topic that I will talk about to anyone willing to listen. So I think this is an area of medicine that is exciting. And so let's get into it. Thank you to Scott for navigating the PowerPoint for me too. So next slide, I have no disclosures. Next slide. So for our objectives today, I do kind of just wanted to explore what I'm calling the continuum of palliative care services. Pediatric or perinatal palliative care is a relatively new field.
Dr. Leadbetter, can I sneak in for a second? I'm so
Yeah,
sorry. I just want to see if everybody would be willing to take a poll real quick. We are collecting data for this so that we can identify if there was learning that happened. So please, for the audience, can you take just a couple of minutes to complete this? I'm so sorry, Dr.
no, that's okay.
All right. Okay, thank you, Dr. Leadbetter.
All right. So if you are at all familiar with the field of neonatology, you are probably well aware that the type of diagnostic and therapeutic options for neonates are more advanced now than they have ever been before. Neonatal providers are seeing babies with complex medical conditions and those of extreme prematurity survive, whereas even just a couple of decades ago, they weren't. So we're going to kind of delve into the palliative care component of neonatal care. And as you're going to discover, this is not necessarily reserved for neonates where we know they have a life-limiting condition, but rather for neonates where the complexity of their medical journey after delivery is going to be significant. So next slide. So perinatal palliative care, if you're not familiar with what it is, the American College of Obstetrics and Gynecology defines it as a coordinated care strategy comprising options for obstetric and newborn care that include a focus on maximizing quality of life and comfort for newborns with a variety of condition. And I italicized the last sentence because thanks to the Affordable Care Act, patients up to the age of 21 can receive both hospice and palliative care services while also receiving life-prolonging therapies. And that's emphasized in that last sentence. So perinatal palliative care can be provided concurrently with life-prolonging treatment. And I think that's an important distinction because that's easy for providers to forget about. Next slide. The other definition that I wanted to bring forward before we got into it was shared decision making. So you're going to hear me talk a lot about shared decision making today. And the British Medical Journal defines that as a collaborative approach by which, in partnership with their clinician, patients and or their families are encouraged to think about the available care options, the benefits and harms of each, and then work with their provider to come up with the best course of action for that patient and their family. So it's essentially finding those goals of care and then working together to try to meet those goals of care. Next slide. So as we navigate each phase, I'm going to walk us through the case of a family that I have cared for in the last year because I think it highlights several of the concepts that we're going to discuss. So the family background, those of us that do palliative care really are well aware that we have to know the details of what this family is bringing to the table. And it also demonstrates to our families that we want to get to know them outside of just a diagnosis, which is exceedingly important in building that therapeutic relationship. So baby A's mom is a healthy 31-year-old woman. She's had 5 pregnancies and 2 prior full-term deliveries. She and her husband live in central Illinois and have 2 older sons that are both healthy. They are both educated, they work full time, they endorsed a strong social support network consisting of family and friends, and they follow the Christian faith. And they denied any economic insecurities, including financial, housing, and food insecurity. So mom had good prenatal care starting in the first trimester. In the 16th week of pregnancy, she underwent non-invasive prenatal testing, which resulted as high risk for a condition called trisomy 13. Her primary obstetrician subsequently submitted an urgent request for consultation with the maternal fetal medicine specialists. At 18 weeks, she was seen by MFM and a genetics counselor, where a detailed ultrasound was performed that showed findings supporting that diagnosis of trisomy 13. That include the baby being growth restricted, having abnormalities in the cranial or central nervous system, and the baby had a complex cardiac defect that was hard to kind of fully delineate at that visit because of the early gestational age. So at those first visits with MFM, they discussed trisomy 13 and what it was and what it meant, as well as all of the different ultrasound findings. And they also discussed with mom what the different management options were for this pregnancy, including confirmatory testing by amniocentesis, continuing the pregnancy, and or terminating the pregnancy. At that time, mom declined amniocentesis and requested another appointment in a couple of weeks just so that she and dad can kind of absorb this information and have time to process it. And they did discuss palliative care at that visit, and mom did request consultation with a palliative care provider because they really just wanted to get as much information as possible. Next slide. So in the 19th week of pregnancy, I met with baby Zay's parents for the first time for palliative care consultation. And this meeting was really focused on thoroughly discussing the diagnosis. These parents had several insightful questions about the diagnosis of trisomy 13 and what that entailed. And at first, at that visit, they really strongly felt like, despite the ultrasound and laboratory findings, their son was going to be born healthy. And as a perinatal palliative care provider, I am well-versed and frequently having to navigate the concept of hope with families. And so I made sure that they understood that I'm hoping for that as well. It would be wonderful if the prenatal testing was not accurate and that their baby would be born healthier than we thought. I think it's incredibly important to help families maintain some amount of hope. I also discussed that if the ultrasound and prenatal tests were accurate, it would be important for us to discuss that and discuss a plan of care that they would be comfortable with. And they really responded well to that dual conversation about maintaining hope while also discussing what happens if the findings were accurate. They did, however, want a second opinion. So the MFM team arranged an appointment with the Fetal Care Center, which is the prenatal care center at Washington University in St. Louis at St. Louis Children's Hospital. And the parents and I agreed to meet again after that second opinion was obtained. So next slide. Let's talk about which patients perinatal palliative care applies to. The patients that I think all of us have most commonly come to mind are those with life-limiting conditions. So that can include babies that we anticipate will not survive long after deliveries, such as anencephaly or bilateral renal agenesis. We also consider those patients where the risks of intensive care might exceed any potential benefits. So that would be some of these genetic conditions like trisomy 13 or 18. We should be referring those for whom the outcome may be poor or where the course is complicated. So sometimes on prenatal ultrasound, we have a finding of a constellation of findings, but we don't have a name for it. We don't have that diagnosis. Brain abnormalities, skeletal anomalies, those with multiple defects affecting multiple organ systems. And sometimes we know the diagnosis, but we don't really know how the baby is going to do. So complex cardiac defects, severe high drops, lower urinary tract obstruction. And at the end of the day, any patient, any baby that is facing a long road after delivery is eligible and should be receiving perinatal palliative care consultation. Next slide. So this table looks at some of the common reasons for perinatal palliative care consultation, and I included it because I wanted to direct your attention to the area of green shading. This illustrates the patient population in the NICU that may benefit from perinatal palliative care consultation. Perinatal palliative care is not just for moms who are pregnant and discussion prenatally. This also includes babies who are born and have medical complexity and are admitted to the NICU too. And I will say you should never and will never find a list that's complete with the diagnoses that should be considered, because there shouldn't be one. Really, this is a field where there's a broad range of diagnoses that would qualify for consultation. And so a finite list just isn't realistic. Next slide. And I included this slide just to demonstrate how referrals for perinatal palliative care are on the rise. So in this study, which was published in 2023, 159 antenatal referrals were received over the study period. And figure 1 on the left illustrates the increase in referrals over time. Table 2 on the right illustrates the wide variety of diagnoses that were prompting referral. Next slide. In 2019, the American College of Obstetrics and Gynecology issued a committee opinion that was subsequently endorsed by the American Academy of Pediatrics. And it's a lengthy document, but it does address a variety of aspects of perinatal palliative care. And I do think it provides a nice kind of high-level look at the goals of that prenatal consultation. So let's get into it. Next slide. So we've already discussed the patient population. As for the different components, first is the initial consultation. And this is where we really get into either the fetal diagnosis or the findings on prenatal testing that are concerning. We introduce the rationale of having a palliative care team involved. And we also review the decisions that at some point they are going to be asked to make. It is not always reasonable or appropriate to cram everything into one meeting. So when it's possible, we're then going to schedule that second meeting or as many meetings as it takes for this family to arrive at a care plan that they are comfortable with. And when I talk about establishing a therapeutic alliance, this is our chance to validate the family's decision. So it is not uncommon for moms and families to arrive at my doorstep, if you will, having already been counseled by the obstetrical team about what their options are for the pregnancy. And sometimes they feel a little uncertain about how much they're going to be supported with whatever that decision may be, whether it's ending the pregnancy, continuing the pregnancy, providing intensive care after delivery, not providing intensive care after delivery. They're kind of living in this area of uncertainty and not always feeling certain that the medical team is supporting that. So this is our chance as prenatal providers to really validate the decisions that they are making. We really need to be approaching this from a place of non-judgment with whatever the family has decided to do with the pregnancy. And it's also the chance for us to ensure that the parents' goals of care align with reasonable expectations for the pregnancy. This is also the time for us to help the families create a birth plan. And for these families, a birth plan is absolutely essential. And I'm going to share in a few slides everything that we include in that document. There should be ongoing conversation with the family for the remainder of pregnancy. And ideally, when possible, having a member of the perinatal palliative care team check in with the families in the perinatal period, or, in my case, where I'm the NICU doctor as well, trying to attend the delivery myself when I'm able to. And of course, there will be ongoing support for the baby and the family post-delivery. Next slide. So a unique feature of perinatal palliative care that I think we all have to remember is that we are basing care decisions on prenatal testing, which does include fetal imaging and sometimes genetic testing, without being able to examine our patient directly. I've had several cases where we thought we knew what was going to have to happen after delivery, and the baby totally threw us a curveball. And so, like many fields of medicine, perinatal palliative care providers really need to be flexible and kind of expect the unexpected. Next slide. So I wanted to explore the birth plan a little bit more because, as I mentioned, this document is absolutely essential in cases of perinatal palliative care. And this is a nice review published in 2020, where the authors really explored all of those different aspects of prenatal consultation. So next slide. Here's a table that is outlining strategies to just how do we explore these goals of cares with these families? What are some phrases and some thoughts we can kind of introduce just to help them start and have the conversation? So reframing their medical understanding, what does this all mean? Acknowledging all the emotions that they're going to feel, because they're going to feel all of the emotions. Helping the families use their own value system to help inform the goals of care that they're going to create for their child. And then proposing a plan. I try to listen to all of that detail and then based on that say, okay, based on what I'm hearing, if it's okay with you, can I propose the plan of action that would best align with those plans of care? And then have a little back and forth with that. So next slide. With the birth plan itself, there's a lot that goes into it. I'm not going to read all these bullet points, but it's not just related to how we're going to physically care for the baby after delivery. It is going to include wishes for during labor. We need to talk about whether we're going to have fetal cardiac monitoring. We're going to talk about whether mom wants to have a C-section if there's signs of fetal distress. We want to talk about who they want to have present in the delivery room, the important members of the team or important members of the family that they would like to have involved in that immediate perinatal period. And then we do get into what is care for the baby going to look like after delivery. So do the parents want anything invasive, or do they want to really minimize and avoid anything invasive? Do they want to have a trial of therapy where maybe we provide non-invasive support for that baby's breathing, but not escalate to anything past that? There's a lot of different nuances to what the care for these babies can look like after delivery. So we have to do our best to tease all of that out before it's go time. Next slide. And then hitting on how we're going to maximize the quality of time that these parents are going to have with their children. So how are we going to best make memories? What are the things that are important to you? Are there siblings around? Are they parents, wanting the siblings to come in to meet this baby? And if so, how can we bring the siblings into the fold and use their goals and their interests and the things that they're curious about to help make memories with this baby? We're going to talk about what happens if this baby lives and is still alive when it's time for mom to go home from the hospital. What is that going to look like? Do you want to take your baby home with hospice in place? If you're not comfortable with that, let's talk about admission to the NICU, where we can continue to provide end-of-life care in the hospital environment. We talk about organ donation. We talk about funeral planning. We talk about social support. We talk about how to keep babies physically comfortable during the dying process. There's a lot that goes into this document, but as you can imagine, doing this after delivery or at the time of delivery is suboptimal. Parents cannot be asked to make these decisions in the heat of the moment. Next slide. And then put it all in a note. Put it all in a note that is easy to read and condensed down. And so that we all have kind of a little template that we use, perinatal palliative care providers. I have about a 3-pager that really delves into this. And then once we have this birth plan created, we have to spread it far and wide. So the primary OB needs to get a copy, the maternal fetal medicine specialist, any other specialists that are involved in the care, the primary pediatrician. I make sure my colleagues in the NICU know where to find this document. I forward it even to the charge nurses and the nurse manager on the labor and delivery floor. Everyone gets a copy of this birth plan, including mom and dad, so that I don't want my parents to ever have to come into the hospital at the time of delivery and then have to rehash what they do or do not want to have happen. They've already had that conversation. It's our job to make sure everyone knows. Next slide. I will stress night and day that these conversations are vital, but there is actually some data out there saying, yes, they are in fact vital. This is helpful for parents. So this was a study published in 2019 in the Journal of Palliative Care, or the Journal of Palliative Medicine. Dr. Donna Maria Cortezo is kind of a giant in the field of perinatal palliative care. And so her research team surveyed parents and physicians about the impact of having a birth plan in place when we know the baby has a life-limiting condition. And there was definitely some common themes that emerged in both groups. Next slide. So when parents were surveyed, they said that having a birth plan in place improved their sense of control, improved communication with the team, increased how prepared they were going into the delivery, and improved the satisfaction that they had with the memory making that they were able to do. The parents surveyed who did not have birth plans in place wished that they had for these same reasons. Next slide. As for physicians, most reported that having a birth plan in place did help facilitate care that was aligned with the patient's wishes. But about a third of the respondents said that they do not have time to sit with families and have these conversations. And then another theme was that there are limitations to a birth plan because it is impossible to know ahead of time how things are going to go after delivery. So flexibility is going to be required of both the family and the healthcare team. Next slide. So back to our case, in the 20th week of pregnancy, mom was seen in St. Louis, where another ultrasound was performed that did confirm multiple anomalies, as we saw in the first ultrasound. And at that time, the cardiac images were able to be a little more defined and were suggestive of a complex cardiac defect with an unbalanced AV canal and a small aortic outflow tract. Given the ultrasound findings, the parents were counseled that the diagnosis of trisomy 13 is likely, although it could potentially be a different genetic etiology, but none of that could be further investigated without an amniocentesis, which mom again declined. At the end of that visit, mom expressed to the team in St. Louis that she was considering ending the pregnancy. And so the team in St. Louis encouraged her to follow up with her providers on the Illinois side of the river to facilitate that. However, the next day, mom called the fetal care center back and said that she had changed her mind. She is going to continue the pregnancy, and she was considering invasive management for the baby after delivery. And so given those wishes that were expressed, they were going to follow in about a month in St. Louis. Next slide. So at 25 weeks, she was again seen at the fetal care center, and she requested an amniocentesis at that visit, which was performed. There was also additional cardiac imaging, which just confirmed the previous findings. At that time, the cardiothoracic surgery team at St. Louis Children's had taken a look at everything, and the parents were told that the baby would likely not be a candidate for surgical intervention for his heart, given the diagnosis of trisomy 13 that was likely, the way the heart was formed with various anomalies, and then also the presence of additional anomalies in other organ systems. At that visit, mom did tell them that she wanted resuscitative measures for the baby after delivery. And the parents were planning on going ahead and following in St. Louis in 2 months. Later on, they were notified that the amniocentesis did diagnose definitively trisomy 13. So as you have probably picked up by now, this family really struggled with how to proceed with the pregnancy. His mom expressed everything from desiring to end the pregnancy to continuing the pregnancy with intensive care intervention for the baby after delivery. So I again met with them at their request in the 28th week. By then, the amniocentesis results had been called to the family. They had had time to kind of think about things and reflect on everything that they had been told. And they had ultimately come to the conclusion that it was in the best interest of their son and their family for baby A to receive comfort care after delivery. So at that visit, we went ahead and created the birth plan. We discussed all the things that I had outlined a few slides ago. And we really kind of delved into optimizing that family time together. The parents wanted their older sons to visit and to spend time as a family. So we talked about what that may look like. And then after that, the parents really did not feel like they wanted to come back in for another in-person visit. So we agreed to follow up by phone. Next slide. So there are many studies out there that have sought to explore the parental experience in the prenatal period while mom is pregnant. So this is an article published in 2016 that was a study of 332 parents who continued their pregnancy after receiving a diagnosis of either trisomy 13 or 18. And I know that there are limitations to a survey-based study, but I do think there are some valuable insights that we were gleaning from this one. So one question asked was, oh, sorry, next slide. One question asked was, what are you hoping for? What are these parents hoping for after delivery? And the reality is they're hoping for the same things that all parents want after delivery. They want to meet their child. They want to spend time with their child and time together as a family. They want to bring their baby home, and they want to give their baby a good life, whatever that means to them. Next slide. So this is another survey. It's a little bit older, but I think it's relevant. It was published in 2013, and it asked about the parental experience and the dynamic with the healthcare team after deciding to continue the pregnancy. So what these parents described was feeling pressured to terminate the pregnancy. And I have had, like I mentioned, several parents who have already been counseled by the OB or the MFM teams. And I don't necessarily think the obstetrical teams are setting out to encourage parents to take one route of action or the other. But for whatever reason, the parents leave that meeting feeling like they were pressured to end the pregnancy. And I've talked to perinatal palliative care providers from various areas of the country, and they have experienced the same thing. So parents endorsed valuing providers that were providing accurate statistics and survival numbers when it comes to outcomes. They wanted providers who were supportive rather than judgmental, kind and empathetic, and who valued their child as a person and not just a diagnosis. So none of these parent perspectives, none of these things that parents value are out of the ordinary. These are the same things all parents want of their children's providers. So when it comes to providing the statistics, I just wanted to delve into this a little bit more, because this is where it's easy for providers to get into trouble. So by way of example, I'm going to use trisomy 13 and 18. A few weeks ago, I presented a similar talk to the obstetrical department at my institution. And when I asked for a show of hands of who was taught that these two diagnoses are not survivable and that intervention is futile, nearly everyone raised their hands, including the current residents. Well, the data shows that while these diagnoses can be life-limiting, there are an increasing number of families opting for active intervention, and these patients are able to live longer. So this is a table from the 2025 American Academy of Pediatric Guidelines for care with patients with trisomy 13 and 18. And we're looking at the rates of live birth in this patient population, which ranges from 14 to 19%. A lot of us are taught in medical school that these pregnancies, for the most part, end spontaneously. That is not, in fact, what the data shows. It showed that a fair number of these babies do survive beyond the first week. And in fact, 10 to 13% were surviving longer than 5 years. So this is just one little example of how the data doesn't necessarily support what providers are being taught in their training, but parents can find these numbers online. So we have to be prepared to help families utilize this information to make decisions that they are comfortable with. Next slide. So one last study, this one was published in 2018, and it utilized 2 online support groups to survey families asking how well supported did you feel by your healthcare team after you decided to continue the pregnancy for a baby who has trisomy 18. And 114 surveys were submitted. Next slide. This is a busy slide. I'm just going to point out the things that I find interesting. And I'm going to focus on the ones related to physicians because that's my field. So if you look at the different data points that are in there, a lot of the patients did feel like they were explained what the trisomy diagnosis was in a way that they understood. Many of them felt like physicians did not provide information in a way that helped them make decisions. Many felt that physicians did not discuss outcomes in a way that was not biased. Many said the physician did not offer them resources about pregnancies with trisomy 13 or 18. And when asked if it was easy to find good prenatal care following their decision to continue the pregnancy, over half the respondents said no. So just another example of how there's potentially a bit of an ongoing disconnect between what providers are trying to convey to these women and what they are actually receiving and experiencing. Next slide. And I'll stop there. I'm talking for an hour and a half is a lot for me. So any questions before we delve or comments before we delve into the perinatal period? You can put them in the chat. Feel free to turn on your mic and ask. I'm all ears.
Dr. Leadbetter, I have a question.
Yeah.
For those families that you create birth plans with, but the anticipated condition at birth is not what was talked about, right? How is the flexibility like with the providers and or the families for anything that changes when they work so hard to create a plan? Because some people are concrete is what where my mind goes. So any deviation from that could be hard.
Yeah, that's a great question. So I think for starters, if there is any question at all about what might happen after some diagnoses, we know if you have a baby with anencephaly, that baby is not going to survive for very long after delivery. So if there are certain conditions for my patients where they want to deliver at a smaller institution closer to home, and if it's a condition where we really know what is going to happen, a lot of those institutions do beautifully with comfort care and helping to take care of those families. If there is any suggestion at all that we may not know how things are going to go, these families have to deliver at a perinatal center where they have a NICU team available to help make those quick decisions. I have had several patients that I've seen for palliative care consultation where there was always a bit of a gray area of, well, maybe we can try to support the baby's breathing, and if that doesn't help, we won't do anything more invasive. Well, that's where a neonatal team who has been updated on what these families have said their wishes are. That's my job to make sure my team is updated. Then quick assessment in the delivery room. And then I certainly feel like we've all had babies where they have survived longer than the parents think that they would. It is not uncommon for parents to just feel like they know that their baby is going to die quickly and they're not going to have a lot of time. And then maybe an hour goes by or 2 hours or a whole day. And so I think just making sure that the palliative care provider that saw that family is checking in with them routinely to get a sense of how are they navigating that? How are they feeling? Because if the family is starting to waffle about what they want to have done, really helping them understand the goals that and remember the goals that they had discussed before the baby was delivered. Because it is really hard to look at a baby that is breathing in front of you and looks perfect. It's really hard to sit there and just continue to focus on comfort sometimes. So making sure that the families know that we are there to support them, that they are making the right decisions for their family. And if it does seem like the baby is healthier than we thought, we need to be honest with families about that and talk to them about that and see, well, would you maybe want us to run an x-ray or do an ultrasound of the heart now that the baby's here, just to confirm the findings that were found before the baby was born. And a lot of times parents are fine with that. If it gives them the peace of mind to continue with the plan of care that they have established, then that's what we need to do. Very long-winded answer. All right, so let's sally forth with the perinatal period, which is defined as the time of labor, delivery, and the immediate postnatal period. So for our case, labor was induced at 37 weeks because the baby was growth restricted. It resulted in an uncomplicated vaginal delivery. And one of my NICU partners was present at the delivery. Baby initially had a weak cry, was placed skin to skin with mom per her wishes. Baby subsequently developed apnea. And the mom kind of requested, can you take him to the warmer? Can you assess him there? The primary OB, my partner that was there, were wonderful with these parents, talked them through it, and it was ultimately decided that oxygen by nasal cannula was acceptable to the parents if it helped the baby transition to life outside mom, but they did not want anything else done beyond that. So baby was placed on nasal cannula support and returned to his mom's arms. After delivery, he never left his parents' room. He looked comfortable on his nasal cannula support, and mom did off and on try to put him to breast or offer him a bottle. We had talked about that before he was born, about hunger cues and how he may not show them. He got to meet his grandparents and his siblings and other family members. And after a few hours, the parents expressed a desire for their baby to have a heart ultrasound, an echocardiogram. So the neonate, my partner that had been there, called me. I was scheduled to come in that afternoon for the night shift, which is why I wasn't around quite yet. And because he wasn't quite sure how to proceed, the document he was looking at said nothing to be done but comfort care. And so he called me and he said, should I do this ultrasound? I said, absolutely, we're going to do this ultrasound. The baby can have the ultrasound done in mom's room. It is not invasive. It is not painful. And if it gives the parents the information they need to continue to feel comfortable with the decision for comfort care, then that's what we need to do. So that is what happened. The ultrasound was done. It did confirm all of the fetal findings. And it did show a little bit of depressed function of the right side of the heart, but nothing that was catastrophic or imminently going to lead to the baby's death. So baby continued to room with mom, continued to be comfortable, orally fed off and on per his hunger cues. Sometimes he'd take some, sometimes he wouldn't. And when mom was ready for discharge, she requested to have the baby come home with them with hospice in place. So that's what happened on day of life 2. In the immediate perinatal period, a lot is focused on assessing how the baby is transitioning to life outside mom, is how I describe it. If there's any, like I mentioned before, if there's any suggestion that the baby might need a quick assessment to decide the proper or the right route of care, then they have to deliver at a center that has a neonatal team to do that. Next slide. There isn't clear evidence that guides how to best physically care for these babies after delivery. Oh, I'm sorry, Scott, slide before this. Thank you. There's not a lot of data out there about the best way to approach this, but centers who have a lot of experience have published their approaches, which really can be helpful. This is an example from the Neonatal Comfort Care Program, which is in New York. And take a note of the third point, mentioning special dressings. So for our babies with gastroschisis or anencephaly or omphalocele, if they're undergoing comfort care, they are going to need certain dressings put in place to help their body be comfortable while they're being held by their parents. So there are videos out there that just, demonstrate how to provide these dressings. So just a lot of really nuanced things that we may not always think about as we're taking care of these babies. Next slide. There's also going to have to be ongoing assessment of not just how the baby is physically doing, but how the mom is physically recovering and how the family is navigating all of this emotionally, spiritually. We do have to have some orders in place. We do have to make sure that the staff members caring for this mom shift to shift understand what is happening with that baby's care. And so some of the routine things like vitamin K administration, having a newborn screen done, the eye ointment prophylaxis, none of that has to happen for a baby that is undergoing comfort care, because we're going to try to minimize the medical things we do for that baby. And that was a really quick look at the perinatal period, because it tends to be the real quick period in this process. So any questions or comments about that phase? All right, let's get into the fun part, postnatal period. So I'm going to start with a study that was published in 2013 that I really like to reference, because it looked at more than 24,000 patients, pediatric patients, who died in the hospital over a 10-year period. It focused on patients who were admitted for more than 5 days, because it wanted to capture those patients that had time to potentially receive palliative care services. So next slide. I included this because even though neonates account for 41% of all the deaths in this population, only 2% had documentation of receiving palliative care services. Older patient age was associated with increased use of palliative care services. Now, what is optimistic for me is that the use of palliative care services did increase steadily throughout the study period, but it really was more thought about with the older patients. Babies really were not a part of the equation just yet. So I think it kind of demonstrates that this is a patient population where we just either aren't used to or haven't really wrapped our minds around the thought of babies receiving palliative care. Next slide. So This is a report that is issued by the National Hospice and Palliative Care Organization. This was issued in 2023, and this is an overview of the use of pediatric hospice and palliative care services in the United States. This is the percentage of pediatric hospice and palliative care providers providing care for each group. And you're going to notice that only 11% report caring for infants less than 1 year of age. So not many providers out there providing neonatal palliative care. Next slide. These are the common reasons for referral. And again, you're going to see that conditions in the perinatal period account for only 14% of referrals. Now, I will say that the reported data does not indicate patient ages in each category. So it is possible that, for example, the genetic conditions category might include some neonates. But just ongoing evidence, again, that the perinatal period is not sparking a lot of thought when it comes to formal palliative care consultation. So once he was discharged home, baby A's parents reported that he continued to do okay. He was eating small volumes every few hours. He seemed comfortable. But within a day or two, mom was kind of starting to think, he's living longer than we thought. So she asked if it would be possible to have him be seen by genetics and cardiology in clinic to just kind of talk through what's happening with him and get their questions answered, which of course we facilitated as quickly as possible. So on day of life 3, he was seen in genetics clinic where they did review the amniocentesis findings with the parents, but did draw a chromosome microarray off the baby because at this point it was very important for the parents to have postnatal genetics done to confirm the diagnosis. They were also asking about trisomy 13 mosaicism, which is a rare subset of these patients, but they had read about it and wanted to see if he fit in that category. So the microarray was drawn. In cardiology clinic, he had another echocardiogram, which confirmed the findings that had already been seen. And the cardiologist, with the parents' approval, did reach out to the cardiothoracic surgery team at St. Louis Children's, just again, to review the case with them to see if he would be a candidate for surgical cardiac intervention. And the CT surgery team there said, no, he's not a candidate at our institution. Throughout all of these visits and all of this conversation, the hospice teams and myself, Dr. Miner, my palliative care partner, we were all in frequent communication with the family so that they were well supported at home. Next slide. So it was actually fairly recently in medicine years, in 2002, that the first neonatal end-of-life protocol was published by Dr. Brian Carter and his colleagues. Dr. Carter is a neonatologist and an ethicist, and he is, again, a giant in this field. So you're going to see a lot published by him when it comes to neonatal and perinatal palliative care. This protocol was innovative and it was comprehensive and included guidance on everything from the prenatal consultation to training staff to provide this type of care to pain and symptom management. So it really was a very comprehensive protocol. Next slide. And then in those early years, there really was not a lot of data out there to inform best practices for neonatal palliative care. But these two figures here kind of demonstrate how the literature has grown steadily. So we have a lot more out there now that we can reference as palliative care providers to see what are people doing with neonatal palliative care and what is working. Next slide. So by way of example, just kind of a look at one study. This is the study that looked at outcomes before, during, and after implementation of a palliative care protocol in the NICU. And this was at a center in Rhode Island. And this protocol included provider education, standardized clinical practice guidelines, and then also communication training for providers and staff. And this study included 106 patients. So this figure here shows the percentage of patients receiving each of these end-of-life interventions, outcome meetings, palliative medicine, ancillary care, redirection of care. And there was a statistically significant increase in the use of palliative medicine and in redirection of care. Next slide. The pre-implementation group had a lot of differences, a lot of variability in how the care was used for each baby, the variability even within one unit in that hospital. So post-intervention, there was a decrease in that variability. And for those of us that practice medicine, we know that having more standardized approaches to patient care leads to better outcomes. So this study demonstrated that for the palliative care world as well. Next slide. And as we've discussed before, centers who have experience have been gracious enough to publish what they have success with. So this is a table that outlines suggestions for how to maximize comfort for neonates through a variety of approaches. So talking about maintaining body temperature, promoting bonding with the family, relief of hunger or thirst. This is a big one. Anyone that does palliative care knows that the concept of hunger and thirst can be very distressing for families. And that is no different for pediatric patients. So I really do talk to families quite a bit about the concept of feeding the baby versus not feeding the baby. We really focus on the idea that if our bodies are dying, forcing food into us actually can be uncomfortable. So I really help parents kind of wrap their mind around the fact that the baby is not eating because they're dying. The baby is not dying because they're not eating. So kind of just helping them remember the dying process and what our bodies do and do not want to have happen during that can sometimes really alleviate some of those concerns. Next slide. So this is a table that looks at how we can optimize comfort for neonates who are already admitted to the NICU and are already receiving intensive care. Palliative care is every much as applicable in the NICU for those for whom we are doing everything we can and it's not working. So talking about encouraging the family to be present, providing privacy, teaching them the ways that they can bond with their baby in a way that optimizes that baby's comfort. So massage and holding, reading, soft music, all the things we can do that not just provide comfort for that baby, but provide the families an opportunity to engage with their baby in a way that they find meaningful. Next slide. And this is a table focusing on how to approach end-of-life care in the NICU. So talking about turning off the monitors. I don't need parents looking at numbers. I need parents looking at their baby. So I tell them ahead of time how we're going to turn off the monitor. Talking about not just pharmacological interventions to optimize pain and comfort, but the developmentally supportive ways that we can improve pain and optimize comfort. So, and then after the baby has died, and a lot of times we are able to go ahead and get all the stuff off of the baby, get that breathing tube out, get the tape off the face, having the parents bathe that baby and spend time with that baby. There is no limit to how long babies who die in the NICU, their parents can be with them as long as they want to be. And for some families, that's a few hours. And for some families, that's a day or two. Both are completely fine. It is whatever the family needs to have happen so that they can find the time that's right for them to then say, we're done and we're going to leave. So next slide. When it comes to pain management, anyone that's familiar with baby care in the NICU knows that there is no standard. We don't know what works best. There's no protocols that are the standard of care for pain and comfort management in the NICU because the data is just not out there. So again, people that are doing it well, share what they're doing. So this is just a table that was published by Dr. Cortezzo and her colleagues. You're going to notice that the first line of treatment for really all patients, but especially babies, is the non-pharmacological interventions. The things we can do in the temperature and with the way the baby is wrapped or held to optimize comfort before we utilize the medication. It doesn't mean we hesitate to utilize a medication. If that's what the baby needs, then that's what the baby needs. There are also several medications that can be administered without the baby having to swallow or use of a feeding tube. So intranasal medications and sublingual medications work just fine for these babies. Next slide. And then this is just another example of algorithms that are out there to inform the type of pharmacological and non-pharmacological interventions that are there for babies. Next slide. I am touching so briefly on trisomy 18, just because this is such a hot topic in general in pediatric care right now, much less in the neonatal population. So as I mentioned before, this is not a diagnosis that gives you the warm and fuzzies. This is still a diagnosis that is that can be really brutal and really heartbreaking for patients and for their families. These babies are medically complex. However, more parents are opting for medical intervention. And so this was a study published in 2021. It was a retrospective chart review of those patients that were admitted to the inpatient setting with the diagnosis of trisomy 18. And the primary outcome was survival to discharge, but they also looked at the rates of surgical interventions. And this was a total of 10,000 admissions over the study period. Next slide. When it comes to surgical interventions, at the start of the study in 1997, only 7% of the cohort had an intervention performed. By 2016, it was up to 42%, and it was across the board: cardiac intervention, tracheostomy placement, gastrostomy tube placement. Ongoing evidence that more families are opting for intensive interventions for these babies. Next slide. And so given the fact that A, we know that with medical intervention, these children do have a chance to live longer, and B, the data is clear that more parents are wanting to provide intensive interventions for these babies, the American Academy of Pediatrics published a clinical report last July of 2025, that provides guidance for caring for infants and children with trisomy 13 and 18. And this really is the first time we've had something published saying, here are the things that you need to consider when you are caring for these patients. I'm not going to delve into the protocol. It's out there. It's long. It's worth a read if you're a neonatal provider. But I do want to speak to a couple of statements that discuss the ethics, because the concept of moral distress as providers, where sometimes we are providing care that may not personally align with what we feel is right for a patient, that is real. And it is not just among nursing staff. There is enough data out there saying team members across all disciplines taking care of children in either the NICU or the PICU experience moral distress with some of their patients. And so what I did want to point out, though, the American Academy of Pediatrics says, although the presence of trisomy 13 does impact prognosis for survival and long-term outcomes, and you can't ignore that, but it is no longer ethically acceptable to not provide care for these patients based solely on the fact that they have trisomy 13 or 18. If the families say that they don't want intensive intervention, that is one thing. But as providers, it is not ethically sound for us to say we will not intervene for these patients. Now, next slide. In the NICU world, a concept that I struggle with every single day is just because I can doesn't mean I should. And so the American Academy of Pediatrics statement does allow for clinician discretion on what interventions are offered in a given scenario. So they say, like other conditions in which patients and their families may not demand inappropriate treatments, there are limits to what clinicians and hospitals are obligated to provide, and they should follow established processes as defined by your institution. Ideally, every institution should have a somewhat standardized approach to how they care for these patients. That's not always the case, but kind of allowing for some latitude with, just because we can do everything, we can do compressions, we can do epinephrine, doesn't mean we have to. It's really, this is where that therapeutic alliance with the family is so important. Okay. So baby A's parents, they readily accepted the decision by the cardiothoracic surgery team that this baby was not a surgical candidate. And so they really focused on keeping him comfortable at home. Again, the palliative care team, the hospice teams, heavily involved with the care for this patient. On day of life 39, his parents noted that he was more fussy and started developing intermittent apnea. Despite those changes, though, he still was eating off and on, and they really did feel like he was comfortable for the most part. Over the next few days, the apnea worsened. He was started on morphine as needed for irritability, and ultimately on day of life 44, he died peacefully in his mom's arms. Next slide. So as a palliative care provider, I really try to reflect on each case that I'm involved in. What am I learning from this? What am I taking away from this? So I like to share that with you. So the lessons I learned from this case, among many, are number one, continuity of care is essential. This baby's parents, they were so thankfully open and honest with the team about what they were thinking and the hard time that they had deciding what they wanted to do with this pregnancy. They were really open about those struggles. But thankfully, they had a core group of people. They had a primary OB that mom knew and liked a lot, who had delivered her other children. They had myself as their primary palliative care provider. They had a core group of team members that they were able to go to express the concerns. And then flexibility is essential. You know, there are providers out there that would not have agreed to do a postnatal heart ultrasound on this baby. There is no reason not to do a postnatal ultrasound on this baby. It's not invasive. It is non-painful. The families, my goal as a provider is always that when parents look back on the care that their baby received, even if none of us are happy with how things turned out, the parents are at least satisfied and comfortable with the care that their child received. They have got to take that away from this time in their lives. And so if doing a postnatal ultrasound or postnatal genetic testing or having a specialist see the baby helps the family with that peace of mind, there is no reason for us not to do that. And then communication is essential. Thankfully, like I said, my partner that was at the delivery did not hesitate to reach out to me. I was in frequent contact with the genetics team, with the cardiology team. We were all talking readily about this baby and how we can best support this family. And then lastly, we need to say their names. If you have talked to parents who have lost children, a common fear is that people won't want to talk about their child or that they will be forgotten. And referring to that child by their name goes such a long way with families to help them remember that you know their child is a child. This is not just a child with trisomy 13. This is baby Angelo. And so we talk a lot about Angelo and about his life. And I spoke with his mom before I gave this talk in a few different forums. Before I created this talk, I reached out to Angelo's mom and I said, can I share his story and can I say his name? And she said, please do. That is all I want. I want people to talk about him. And if he can help one other baby, then we need to do that. And so thankfully, she's been wonderful about this. And so saying their name, helping these parents know that their child is not forgotten and that their child is valuable. Next slide. So looking towards the future of perinatal palliative care, there's a lot coming down the pike when it comes to research. Again, data is still emerging to inform best clinical practices, but if you search for perinatal palliative care articles just published in the last couple of years, there's a wide variety of topics that are emerging. And investigators are asking more broadly about which patients can benefit from this. They are researching the parental experience. They're trying to figure out how do we teach these concepts to the providers coming after us. And then also addressing moral distress. How do we help providers navigate the emotional challenges that can come with caring for patients who have complex conditions? Next slide. Oh, yeah, there's those other articles, yeah. Education. In-person training options for perinatal palliative care in the United States are limited. As far as I could find, this is the only conference that is dedicated exclusively to perinatal palliative care. It is through the Neonatal Comfort Care Program in New York. I've gone to it twice. They are not paying me to say this. It is an outstanding conference. And so highly recommend if you're interested in receiving some education in this field. Next slide. There are also some books that are just well-written resources. The Handbook of Perinatal and Neonatal Palliative Care, outstanding quick guidebook for a lot of different topics in this field. And then of course, Neonatal Palliative Care for nurses and just perinatal palliative care in general. There's some nice books out there that provide some resources to reference. Next slide. We also need to talk about access. As I mentioned, there are not many providers out there who are trained or comfortable with taking care of neonates who need palliative care services. This is news to me. I was thrilled to learn that Northwestern University's palliative care fellowship has a perinatal palliative care track on it. As far as I know, that's the only one out there in the United States. And I think it's awesome. I don't know how it's going. It sounds like it's just been figured out in the last couple of years, but this is awesome because certainly adult providers who provide palliative care aren't always comfortable taking care of pediatric patients, much less neonates. Some of the pediatric palliative care providers out there don't have a lot of experience taking care of neonates. So anything we can do to provide education and increase the access for these patients is going to be vital. Next slide. If you ever wanted to look to see which perinatal palliative care programs are out there, this is the only central location maintaining some sort of list. The perinatalhospice.org website was founded in 2006 by a journalist named Amy Kubelbeck, who had a pregnancy with a child with a life-limiting condition. So this is very near and dear to her heart. This is the only place you're going to find a central repository for the programs that are out there providing perinatal palliative care. Next slide. There are some really lovely resources that have been published for, people like me who just kind of wanted to get things up and running, providing palliative care, perinatal palliative care at my institution. A lot of perinatal palliative care programs are one provider who's doing this with their patients. And so here's an article published in 2020, just kind of outlining some of the things we need to think about if we're going to develop a perinatal palliative care program. And then the next two slides outline just some suggested reading. There's a rabbit hole you can fall down for palliative care, for perinatal palliative care, just like everything else. And so there's some lovely articles just providing general overview, looking at the competencies that we need to try to master as perinatal palliative care providers. And then also, next slide, looking at symptom management and program development. So my contact information is on the next slide. I am always game to talk about this topic. So if there's anyone that that wants to reach me for any reason, those are my contact details. And then lastly, I'm going to say that this talk was for Angelo. And I hope I've given you food for thought today about these complex patients. Their lives are sometimes short and oftentimes complicated, but that doesn't diminish the value that they bring and the joy that they bring to their families. So thank you for your attention. We have some time for conversation. Thank you.
Does anyone have questions for Dr.? You were so thorough, Doctor.
It's hard to find the right balance of chatting and a 90-minute time. Even I have a limit on how much I can listen to myself speak. So
it was unbelievably rich. Yeah. I'm going to share the post test. So if everybody could complete this, that would be amazing.
And additionally, we will be sharing a feedback survey for you guys in the chat. We would love to hear what you thought about the education session. And then additionally, if you need CEUs, please make sure to fill that out as well.